Good afternoon. We are here at the Multiple Myeloma Debate meeting in Copenhagen, Denmark, where an international audience has gathered to hear about the latest developments and especially about presentations that were given at ASH that will change the practice of multiple myeloma. So I'm here sitting with three friends and experts. Professor Michele Cavo from Bologna, the University of Bologna School of Medicine in Italy. Professor Jesus San Miguel from the University of Pamplona in Spain. And Professor Meletios Dimopoulos from the Alexandria Hospital and University in Athens, Greece. Yeah. Welcome to this meeting. Today we have discussed about a number of different topics that are important for our daily clinical practice. And we started with new data from ASH about transplant eligible patients. And Dr. Cavo presented some important novelties. Maybe you can summarize them for us and explain how it will affect our clinical practice.
Yeah, at last ASH meeting, several previously reported trials, including novel agents as part of the autotransplant sequence, were updated. In particular, two trials conducted by the Ovon German group and the Italian GMEMA trial were updated, confirming the value of the incorporation of bortezomib into the autotransplant sequence as part of induction before transplant and consolidation or maintenance therapy after autologous stem cell transplantation. All these trials confirm the progression-free and overall survival benefit with bortezomib when incorporated into the autotransplant sequence, and more importantly, there is a sort of general agreement in focusing the impact of bortezomib in patients with a high-risk cytogenetic profile. So the first conclusion is that bortezomib may be of value when incorporated into transplant in patients with a high-risk cytogenetic profile. A second hot topic is related to the number of transplants to be given single versus double, and a retrospective integrated analysis taking into consideration patient-level data from three European phase 3 trials addressing the role of bortezomib versus a non-bortezomib based transplant provide demonstration that in comparison with a single transplant, a double autologous stem cell transplantation was of value in significantly extended progression-free survival and overall survival. And in this analysis, we were able to identify three different adverse prognostic variables, including a high-risk cytogenetic profile, an advanced ISS clinical stage, and failure to achieve CR after induction therapy. Results showed that in comparison with a single transplant, the patients who had a high-risk cytogenetic profile and failed to achieve CR after induction had a progression-free and overall survival benefit when receiving a double autologous stem cell transplantation. Taken together, all this data can allow us to conclude that there are data supporting the incorporation of bortezomib and incorporation of bortezomib into a double autotransplant procedure in patients with a high-risk cytogenetic profile, particularly patients with 17p deletion and or 1q.
So for the panel, would these findings, would this affect our daily clinical practice right now?
I think so, particularly for the high-risk population, patients with adverse cytogenetics. the data on proteasome inhibitors induction plus double autologous transplant is really encouraging, and I think this is going to support in many centers outside of clinical trials, daily practice, the use of this approach.
Yes, I agree. I mean, for patients who are treated outside the clinical trial, after this data, we discuss with them the potential benefits of tandem autologous transplant for patients who have 414 and or 17p deletions. So I think already these analyses are applicable in our daily practice.
So I regard this as a big step forward, because now we can identify high-risk patients and we can do something for them.
No doubt.
So the next question is about the non-transplant setting. I mean, the majority of the patients will not be transplant eligible. What's new for those patients?
At the last ASH meeting, it was presented one of the largest, probably the largest trial so far conducted in non-transplant candidate patients. This was called the first trial, in which 1,600 patients were randomized to receive either one of the standard of cares, MPT, versus lenalidomide plus low-dose dexamethasone for 18 cycles or until progression. The results from this study shows that lenalidomide plus dexamethasone until progression is significantly superior to the two other arms in terms of PFS, with median PFS of approximately 25 versus 20 months, and not only PFS, but also overall survival upon comparing continuous treatment with Len-Dex versus MPT. In addition, this trial showed that the tolerability of the Len-Dex combination was pretty good, only some non-hematological side effects, minor side effects, such as cataracts, etc. But I think probably we are going to have one new standard of care, alkylator-free, in the near future.
So when do you think this will have some effect on our daily clinical practice?
I think as soon as it's approved by the authorities, not yet.
So then Len-Dex will be the kind of a new standard?
Another new standard. Then I think we can congratulate for the patients if eventually we have several new standards, because each one may have different opportunities for the patient. I think this was the most important presentation. There is another interesting study also presented, this one by the Spanish group, in which they have used MPV, one of the standard, bortezomib, melphalan, prednisone, plus lenalidomide, dexamethasone, for 18 cycles, either in a sequential platform or in an alternating form. And the preliminary data are really encouraging, with very high response rate and apparently the very prolonged PFS, but the data is still immature. And just to conclude, I think we should also congratulate about other new drugs that are being tested already in the newly diagnosed patient, and this includes the second generation proteasome inhibitor, carfilzomib, in combination with lenalidomide, dexamethasone, highly effective. Other combination also very effective, no peripheral neuropathy. And also we have now in first-line treatment, newly diagnosed patient, the use of an oral proteasome inhibitor, ixazomib, that is like the twin brother for bortezomib, very low peripheral neuropathy and high activity in combination with lenalidomide, dexamethasone. And I think the panorama is very attractive.
Okay. So
if I can briefly comment the results of the first trial, which have been perfectly addressed by Professor Miguel, I would like to emphasize that there was no signal of increased SPM for patients receiving continuous lenalidomide therapy. By the opposite, an increased incidence of SPM was seen for patients in the MPT arm of the trial, suggesting the potential value of exposure to alkylating in predisposing patients to develop a second malignancy. I think that this is another important finding of this trial.
Alkylating agents with IMiDs.
Yes, alkylating agent with IMiDs.
So we're moving maybe to a stage where alkylators are no longer the first choice of treatment, but for the time being, with MPV, MPT, it's still an option that's valuable for especially the non-transplant setting.
And as has been already alluded by Professor Dimopoulos, with MPV there was not signal of increase in second primary malignancy. The good news is that lenalidomide in combination with dexamethasone has not signal of second primary malignancies.
And these results further confirm prior results coming from MN 9 and 10 trials showing that continuous exposure to Lendex for patients with the resistant relapsed disease was not associated with an increased incidence of SPM. So I think that we have now robust data supporting that the continuous exposure to Lendex for transplant ineligible patients and not receiving alkylating agents is avoid of any risk of increased SPM.
Okay, so speaking about the relapse refractory setting, Professor Dimopoulos, what can you tell us about the novel, the newest development?
Right. I think the major presentations attached to this meeting were an update of the pomalidomide low-dose dexamethasone trials. The primary trial was published by Professor San Miguel a few months earlier. In these updates at the ASH meeting, a significant improvement in the overall survival was confirmed with longer follow-up, despite a significant crossover percentage of patients. And also, there was an update on the improvement of quality of life of patients treated with pomalidomide low-dose dexamethasone, and the benefit that this combination gives to patients with adverse cytogenetic features, especially 17p deletion, which is in contrast to its brother compound lenalidomide, where we know that both in the relapsed and also in the frontline setting, lenalidomide does not appear to be very active in patients with adverse cytogenetic features. With us, with pomalidomide and low-dose dexamethasone, things may be different. Also, there was another interesting trial from the UK, which for the first time evaluated the role of salvage autologous transplant in patients with myeloma. So at the time of relapse, patients received a bortezomib, doxorubicin, dexamethasone combination, and they were randomized to receive either high-dose melphalan with stem cell rescue or low-dose cyclophosphamide maintenance, and there was an advantage of high-dose melphalan. So I believe this should impact our practice, and we should keep in mind that when we have a younger patient, especially with stem cells stored, if the patient derived a significant benefit from the frontline therapy and high-dose transplant upfront, then we should think of a salvage high-dose therapy after the patient has been reinduced into remission.
The relapse refractory setting is typical the setting where we test novel agents. And at ASH there were several presentations about new drugs and new mechanisms of action that may be introduced in multiple myeloma. Would you like to elaborate a bit on that?
Absolutely. Yeah, I think the most promising class of agents are the monoclonal antibodies today, and especially the anti-CD38 monoclonal antibodies, and we have already 3 in development. Of those, daratumumab has been tested more, so we have robust phase 2 data of single-agent daratumumab, and we know the appropriate dose and a response rate which is approximately 40%, and this is very encouraging because we are talking about patients with relapsed refractory myeloma, and it is clear that trials in evolution that combine anti-CD38 monoclonal antibodies with lenalidomide dexamethasone or with proteasome inhibitors will provide new treatment options for patients with myeloma. And one could envision that in a few years we will be able to give frontline therapy that will include a 4th category class of agents, monoclonal antibodies. So I think this is a pretty exciting period. Also, new histone deacetylase inhibitors are being evaluated. We have encouraging data apparently with panobinostat in combination with bortezomib and dexamethasone, with a 4-month improvement in PFS, but also a newer histone deacetylase inhibitors that are more specific, less toxic, better tolerated by the patient, and this also will provide probably a 5th class of agents that could be combined with other agents for myeloma.
Thank you. There are more classes of agents also being tested, like pathway inhibitors, kinase inhibitors, and so on. But maybe we should move to 2 other important topics that were discussed at this meeting, which are dealing with management of multiple myeloma. Because in addition to our traditional diagnostic procedures, I think over the past few years we have learned that FISH analysis of the bone marrow, especially diagnosis, has an important role. And there are other ways to monitor disease once the patient has been treated. So let's start with FISH. How should we use FISH in daily clinical practice, and when should it be done?
I usually do FISH in every patient at the time of diagnosis, and my daily clinical practice is to perform FISH at every subsequent relapse. FISH provide important prognostic information, and now, although we have not a standard risk-adapted strategy, we can try to move to different treatment decisions based on the FISH profile of every single patient. So FISH is of crucial relevance, and its routine application should be strongly encouraged for every patient, included or outside the clinical trials.
I have a slightly different approach. We perform FISH in every patient at the time of diagnosis, but at the time of relapse, outside the clinical trial, we only repeat FISH if at diagnosis was not high risk. If it was already high risk, we don't repeat.
And yes, you do that with the purpose of seeing whether a more aggressive clone.
Yeah, in a standard risk, they may become high risk.
I agree. I omitted to say this, the importance of repeating FISH is to capture new genetic lesions not previously shown. So it is important.
So have our procedures for imaging in patients, have they also changed?
I think so. And I think they are going to change very much in the future. I mean, just to have a lytic lesion, you need to lose at least 30% of the bone substance. Otherwise cannot be detected by conventional X-ray. This means that this is a low sensitivity technique, and I think low dose CT is going to become more and more popular and probably one of the standard of care for evaluation of bone disease, together with MRI, and I think these 2 techniques are going to have a critical role in the management of patients. And on top of this, similar to what the lymphoma doctors does with the PET, just to measure the metabolic disease, I think the myeloma doctors, we are going to use also PET in the near future, just to evaluate the extramedullary disease, to evaluate the response after intensive therapy.
Last topic that I want to discuss is about how we should monitor the patients, because we have now more effective treatments, more patients achieve a CR. CR rates have doubled or tripled in transplant eligible and maybe doubled in younger patients compared with 20 years ago. So what is our criterion for a good response, and how should we monitor those patients?
Do you want me to address this question?
Yes, why don't you start?
Okay.
Yeah.
Okay, I think the current definition of complete response is based on 2 techniques that are not very sensitive, but very valuable. One is M protein, immunofixation, and the other is the morphology. Nevertheless, I think we need more sensitive techniques. Outside the bone marrow, I think the PET scan is going to be the most valuable one. And inside the bone marrow, I think we need more sensitive techniques to assess the clonality, the residual clonality. And this comes from the high sensitivity flow, the new flow with the 8-color flow, and also the molecular technique, mainly based on the approach that is the next generation sequencing.
So, Dr. Dimopoulos, is CR still the standard that we should try to achieve? Or
I think so, and I fully agree with Professor Jesus and Miguel. And we have to keep in mind that immunofixation is pretty subjective. I mean, the evaluation whether this patient has a negative immunofixation or a positive immunofixation frequently depends on the interpretation of the person who reads it. So definitely we need more objective means of assessing response. And I believe that with newer regimens increasing the complete response rate, we need definitely to have better tools to assess objectively the response rate, and then probably perform trials that will address the question: should we treat patients who have minimal residual disease, for example, detected by flow cytometry? Will this change their outcome? Like in other diseases, we know that in acute lymphoblastic leukemia, this has become the standard of care, and I believe that it won't be long before this will be the same for myeloma.
Any other comments from the panel?
I would like to echo what already addressed by Professor San Miguel and Dimopoulos. The treatment paradigm is changing. We have introduced into the new treatment paradigm for myeloma patients new treatment phases, including consolidation maintenance. All of us agree that our goal in the novel agent era is to achieve the deepest level of response as evaluated by laboratory and imaging techniques. Many treatment phases and the choice of many treatment phases may be based on the achievement or not of MRD negativity. So at this time there is the need to include MRD assessment in every controlled clinical trials, because based upon these results we may provide useful information to be translated into the daily clinical practice in the next few years.
With this, I would like to end and thank the panel for the discussion.
Thank you for the opportunity.